what do you want to do about thoracic outlet? What are the types of thoracic outlet syndromes?
So arterial, venous, and neurogenic.
Okay, so neurogenic, good. Neurogenic thoracic outlet syndrome. The other one is what?
Arterial thoracic outlet syndrome.
Vascular.
Vascular.
Could be arterial or venous. Good.
Venous.
And the third, last one?
Sir, nerve.
Actually, there is one more entity called as non-specific, where you try all these and you cannot get an answer. So that is called as non-specific. So now you have got to tell me, Nikhil, what are the symptoms of thoracic outlet syndrome? What will you see in a patient? So in your patient, when you're examining, what are the symptoms you're looking for?
So pain along the ipsilateral forearm.
Yeah.
Tingling, pin-pricking sensation.
Yeah.
And which the symptoms are more aggravated on raising the arm.
Okay.
In case of artery, in any of the, while in case of arterial, I'll get a claudication pain.
No, clinically you're examining the patient. What symptoms will you see? So one, you said tingling. Okay. What else do you look for?
So the arterial pulse, decrease in the arterial pulse.
Yeah. What else will you look for in the hand?
Sir, edema, swelling, dilated vessels, veins.
You look for?
Dilated veins.
What else will you look for?
Sir, wasting of muscle.
Good. So muscle wasting. I agree with you. Okay. Then you said numbness. Okay?
Yes, sir.
All right. And you said pain and aches in the thing. Completely agree. What else you want to look for?
Sir, dilated veins.
Yeah. What else? In the hand, what will you look for? Wasting of muscles. So how will you examine? What do you get when there's wasting of muscles?
Fatigue.
Yeah, fatigue on what? What are we talking about?
Fatigue on clinching. No, sir.
What is that called as? Whenever you get a nerve problem, you get a sensory problem and you get a
motor problem.
Motor problem. So motor problem, what is the symptom?
Weakness.
Motor element, what is the symptom?
Weakness.
Weakness, yeah, absolutely right. Particularly on gripping. Okay,
yes,
so remember these four things, okay? So muscle wasting, numbness and tingling, pain, and weakness in the weakness of the grip. Okay, these are four symptoms. So in a thoracic outlet syndrome, when you take a history, you must ask for these four things quite specifically. There are more symptoms, I'll tell you about it, but these are very important. These are the ones that you have to ask. So this is your typical, okay, so this is muscle wasting. See this? Can you see this?
Yes, sir.
The muscle is wasted. You have to look for these things when you are examining the patient, okay? And so these are all the symptoms here very clearly, particularly when you're doing with vascular things. So you have got to look for pain, paresthesia, numbness, color change. You forgot to say color change. You forgot to say about temperature, coldness, yeah, and weakness.
Yes, sir.
So remember these, when you got a case in the exam with neurovascular TOS, remember to ask these symptoms particularly, okay? Specifically, you must ask. Okay. What other symptoms? We said cold fingers. We said arm fatigue with activity. We spoke about numbness. We spoke about weakness. And one more thing that you have to look for is any throbbing lump near the collarbone. Okay. Why throbbing lump near the collarbone? What does that suggest?
So thrombus in the vessels.
Thrombus in the vessels, or what else?
Aneurysm.
Okay, so you can
post-stenotic aneurysm.
Yeah, post-stenotic. Okay. So if it's a venous thing, then specifically you're looking for swelling, you're looking for cyanosis, you're looking for pain, heaviness, collateral veins. Okay. You covered all of this. So only by history you can actually make out whether it's venous or arterial or neurological. Okay, quite important.
Yes.
So this discoloration, see this? This is very classical of venous.
Yes, sir.
So you must look for that, or you will get these sort of venous discoloration in the periphery. Okay. Then you might get this throbbing. Can you see? I don't know if you can see clearly, but there is a swelling here.
Yes, sir.
Yeah, and that is evidence of post-stenotic dilatation. And then we spoke about dilated veins on the skin. Okay.
Yes,
So
sir.
this is called as Paget-Schroetter's syndrome. This is an MCQ, by the way, Paget-Schroetter's syndrome. Yeah, axillary vein. And in what, how do you see that? What is this? When do you see this dilatation? Classically?
Sir, above the, sorry, below, above the azygous vein, sir. Block is the,
Yeah, but classically, what will the patient say? He gets these dilated veins when? Look at the top here.
sir, on raising the arm
No, it is usually classically seen when they exercise.
with the exercise.
You have to say this in the history, okay? They say you'll find this when they exercise or when they lift weights and things like that. They classically get this dilatation on the chest. This was a patient who was a bodybuilder, okay? And he used to get these dilatations every time he raised muscles, raised the weights, okay? So
Yes, sir.
all right. So what are the standard causes of TOS, thoracic outlet syndrome? We spoke about anatomic structures. We spoke about poor posture, trauma, repetitive actions, pressure on joints. Pregnancy can cause thoracic outlet, okay, by changing the physiology there. So standard causes is, why do you get thoracic outlet? Anatomically, what are the causes of thoracic outlet?
So the cervical rib, compression, so sir, thrombus.
Yeah, but causes, why do you get thoracic outlet? One is cervical rib. What else?
Raynaud's disease.
C7 process elongation. Okay?
Elongating.
All right. What else?
So there is a band. It's like a cervical rib only. Band.
Cervical band. Yeah, no, cervical band, that is different. Yeah. Okay.
Yeah.
Abnormalities of the first rib or clavicle, which is tumor or callus or things. What else? What will cause compression in the triangle is what I'm asking. What else?
Lymph nodes, tumor.
Yeah, Soumya, come in.
Yeah, lymph nodes, tumor.
Lymph nodes, tumor, what else? Anatomical variations of what?
Scalene muscle.
Good, anatomical variations of scalene muscles. And the last one, what's missing from this list is the fibrous band. Yeah? Okay. So now, Nikhil, you tell me, how will you clinically examine this patient? What are the tests available to you?
Sir, Adson test. Sir, test for a to demonstrate a venous, arterial, and nerve compression.
Okay, good. Well done. So how do you do the test? Tell me Roos test. How do you do Roos test? ROOS, Roos test. Do you know that? Are you there or not there? I can't see you move. What's happened? Hello? Soumya, do you want to take? How do you do Roos test? Do you know?
It's a hyperabduction test.
Okay.
Patient is asked to raise the arms to the level of the shoulder and then try to extend it behind. And that compresses the space, and that elicits a tingling and pain in the affected area.
And what else has changed? Are you feeling for the pulse or not?
Deep inspiration. Yeah, you feel for the pulse and you make the patient inhale.
Okay. So I'll show you the video of the Roos test. Okay. Just 1 second. The Roos test is a test. Can you hear? Thoracic outlet syndrome.
Yes, sir.
And according to Gilliatt et al. 2001, it has a sensitivity of 84% and a specificity of 30%, which means that you'll get a lot of false positive tests results with this test. According to Watson et al. In 2010, the Roos test is testing all 3 intervals where you get thoracic outlet syndrome. The Roos test is performed in sitting or standing position. Ask a patient to abduct the patient to 90 degrees, externally rotate and flex the elbows to 90 degrees. The elbows should be slightly behind the frontal plane. Now ask a patient to open and close the hand for 3 minutes. The test is positive if your patient experiences pain, ischemic pain, or nerve or tingling or numbness of the hand. Also look for discoloration of the hand. Minor fatigue and distress are not a positive test. Okay, is that clear? Is that clear to everybody how to do Roos test?
Yes, sir.
We seem to have lost Nikhil. Okay, all right. Samya, you want to come in the forefront? Are you okay? Are you comfortable with that?
Not exactly, sir. Day before the
this
exam.
is a difficult one. Yeah, I know. This is a difficult one. But take your chances. It's okay. This is the way we learn. Let's do all the tests if that's okay. If any of the other guys want to take the question, please take it. Okay, I'm quite happy. How do you do Wright's test?
Sir, can I take this?
Yeah, yeah, please do. Mohammed Raza. Wright's test. W-R-I-G-H-T. Wright's test.
Yes, sir. This is a hyperabduction test in which a patient is asked to first that he should abduct the arm to a 90 degree,
Yeah,
then flex the forearm to a 90 degree,
yeah.
then clench the wrist and check for the radial pulse and color discoloration.
Okay.
Then
So,
again he is asked to hyperabduct above the shoulder and then again check radial pulse and
yeah. So in Roos test, you are not feeling for the pulse, but in Wright's test, you're feeling for the pulse, and you are doing two positions. One is at 90 degrees and then hyperextension. Okay.
Yes.
I'll show you the.
Today, I'd like to show you the Wright's test, which is also known as the hyperabduction test. It's the test used to check for thoracic outlet syndrome. There are a lot of different descriptions of the performance of the Wright's test, which is why we don't find it reliable to give the numbers on the statistical values of this test. The Wright's test is performed in 2 steps. In the first step, bring your patient's shoulder to 90 degrees abduction, externally rotate and flex the elbow to 90 degrees. In this way, you're stretching the pectoralis minor tendon through which the brachial plexus is positive. For the test to be positive, you have to feel for the radial pulse and see for reproduction of symptoms. In the second step, hyperabduct the shoulder. This way, you're compressing costoclavicular space. For this test to be positive, you have to look for radial ablation and reproduction of the symptoms. So in the Wright's test, you must remember that the first one is for pectoralis area, okay, subpectoralis. And the second movement, when you go hyper abduction, it is actually for the costoclavicular area. Okay, so 2 separate areas you are measuring. As I showed you, there are 3 areas in the thoracic outlet: the scalene, the costoclavicular, and the pectoralis minor muscle or the subcoracoid process. So first one, when you go at 90 degrees, you're actually doing the pectoralis area. And when you go 90 degrees, when you go hyper abduction, then you are doing the costoclavicular area. Okay, is this clear? Yes or no?
Yes, sir.
Yeah?
Yes, sir.
Okay, Mohammed, come in. Raza, come in and tell me the next one. Costoclavicular maneuver.
Yes, sir. This in this test, the examiner go behind the patient and ask the patient to sit comfortably and do a scapular retraction and scapular depression. Then is the scapular elevation and scapular protraction.
Well done. Okay. Sorry, just 1 second.
In this video, we're going to show you the costoclavicular maneuver also known as the military brace test for thoracic outlet syndrome. Thoracic outlet syndrome is defined as a neurovascular complex which is due to compression of a brachiovascular bundle, which is the brachial plexus, the subclavian artery, and the subclavian vessels. There could be compression of the brachiovascular plexus in three areas. One is the scalene triangle, one is the costoclavicular junction, and the angle of the coracoid process. The structures could be compressed by subclavius or the costocoracoid ligament. There is no sensitivity or specificity value associated with this test. This test shows you which positions provoke and relieve the symptoms. The patient is done in a sitting position. The patient is asked to do a scapular retraction, B, scapular depression, scapular elevation, and B, protraction. Each position is held for up to 30 seconds while the patient rests his forearms on the thigh. You monitor the change in pulse and try to document which position exacerbates or eases the symptom. Recommended modifications are to perform both arms by the side and hold the position for 1 minute. You could use military braces to cause backward and downward movement of the shoulder. Thoracic outlet syndrome is defined as a neurovascular symptom complex associated with compression of the brachial bundle, which includes the brachial plexus and or the subclavian vessels. This compression may be caused by several anatomical structures in one or more of the following three compartments: the interscalene triangle, the costoclavicular space, or the retropectoralis minor space. The Ceriax test, the Ceriax release test, is supposed to produce.
So tell me about the Ceriax release test. Nikhil, you want to take this? Hello?
Sir, actually I have an unstable network. I'm just logging in from another device.
Raza, take it.
Yes, sir. In Ceriax release test, again, the examiner stand behind the patient and ask the patient to take the arm at 90 degree and relax on this side of the body. Then examiners take behind the, like in a shoulder protraction, and externally rotate at the back side and feel the radial pulse at the back.
Release of the compression of the neurovascular bundle at the three areas. The Ceriax release test has a specificity of 94.7% when held for 1 minute and 87.8% when held for 3 minutes. But there is no data available on the sensitivity of this test. To perform the test, have the patient in sitting position. The physician stands behind the patient, grasps under the forearm, holding the elbow at 80 to 90 degrees, while maintaining the forearm, wrist, and hands in neutrals. The therapist then leans the patient posteriorly approximately 15 degrees and then elevates the shoulder girdle. This passive shoulder girdle elevation of both shoulder girdles is held for up to 3 minutes. This test is considered positive if either a release phenomenon occurs or the patient's familiar symptoms are reproduced. This test is based on the theory of the release phenomenon, which follows decompression, release of the decompression of one or more of the three areas.
So did you understand this release test, guys? What you're doing is you're elevating the whole clavicle and the shoulder. So when you elevate the clavicle. See, normally, if your hand is hanging by the side, everything is being pulled down. So your scalene muscle is being stretched, your clavicle is being pulled down, so costoclavicular area is being stretched, and your coracoid process is hanging down. So your coracoid process is being stretched. When it gets stretched, it can cause compression. So what you're doing is you're undoing the stretch. So you hold the hand at 90 degrees and lift up the shoulders. The important thing is to lift up the shoulders. So when you lift up, you're physically lifting up the base of the triangle. So when you physically lift up the base of the triangle, you are actually causing release of the symptoms. So patients who's getting symptoms will get relief when you do this. Is it clear? Yes or no? Just give me a feedback.
Yes, sir. Yes, sir.
Yes.
Whether you're listening or not listening or what. Okay, what is Morley's supraclavicular pressure test?
Sir, it is the supraclavicular fossa palpation in which we want to elicit the brachial plexus.
Excellent, very good. So you're actually, when you're putting the pressure, you're actually causing compression. You're creating a compression, and then you want to see what is the
or
thing.
the brachial plexus compression test compresses the neurovascular bundle in the supraclavicular fossa. No diagnostic accuracy studies have been conducted reporting specificity or sensitivity. Hence, the clinical value remains questionable. To perform the test, have your patient sit upright with the arms on the side of his body. The examiner then compresses the supraclavicular fossa for 30 seconds. This test is considered positive if there is a reproduction or an aching sensation or atypical pain or paresthesia or tenderness of the area. In some cases, even a palpable hard mass can be palpated in the supraclavicular space, and this might give you an indication of a true structural problem which may be causing the thoracic outlet problems.
So
These tests may be positive in both cervical radiculopathy and also in thoracic outlet syndromes. Hence, you've got to be careful when you're interpreting this test.
okay, so the point I'm trying to make is, if in the exam you ever get a thoracic outlet syndrome case, it is likely you may get it. This is the best case to get in an exam, because there are a lot of signs that you can physically demonstrate to the examiner. So the discussion won't go so much into management, but a lot of time can be spent physically examining the patient and demonstrating to the examiner. So this is a case where you can get 8. Okay, you can get 8 out of 8. So remember, don't get upset if you get a thoracic outlet syndrome. It is actually the best case to get. Whether you get the symptoms or not, it doesn't matter. It's just the technique of doing the examination. If you can demonstrate to the examiner all these tests which I'm showing you, you will get an 8 out of 8, because finally the management discussion will be less, but the clinical examination will be higher. Okay. As compared to that, if you get a case with a lung cancer, then a lot of discussion goes into theory, into management of the patient, and a lot of literature and things like that. So always, if you get a thoracic outlet syndrome, you must take it as an opportunity to get 8 out of 8, because that will make up, if you've had a bad area somewhere else. Okay, who else is there? Is anybody else there who wants to take this? Or you, whoever. Raza, if Nikhil is not here, you can take it. What is Eden's military brace test?
I'm going to show you the Eden's test.
This is a little bit confusing.
Okay, so shall I play the video? Nikhil, do you know this test?
It's a little bit, sir, not
okay. You must know a lot more. Okay, tell me quickly.
Sir, the hands are by the side of the body, and no, sir, I'd like to pass.
Okay. Now, my suggestion to everybody who's on this group is that the best way to learn all these tests is to keep this presentation or these videos in front of you and do it with a friend. Until and unless you do it with a friend, you will never learn. Now, what I'm showing you, this is my son. and I'm doing it on my son. So, you know, it helps you to practice how you do this test, okay?
For the military brace test, we're going to, this test actually compresses the neurovascular bundle in the costoclavicular space, and hence it's called as a costoclavicular syndrome. But there is no diagnostic accuracy of this space, as we don't know the specificity or sensitivity of this test. To perform this test, you have to stand behind the patient, ask your patient to sit straight in a military position with your chest pushed out and shoulders pushed back. The treatment, the physician brings the arms down and straightens the thing and pulls the shoulder back and palpates for the radial pulse while the patient is stretching backwards. You feel for the radial pulse. If there is loss of the radial pulse or if there is pain, then this is a positive test.
So this is very easy. There is nothing difficult about this test, okay? There should be no confusion about it. It's very easy. You just have to feel for the pulse and brace the hands back and pull the chest forward. That's all you're doing. Is it clear? Hello?
Yes, sir.
Yes, sir. Yes, sir.
Very easy. It's not difficult. Don't get confused. The thing is, there are so many tests that you forget what is what test. But it's a very easy test. All you have to do is just get the guy to sit up, put the hands down and stretch it backwards. So the shoulder should be, the chest should be forward, shoulders should be going backwards, and you have to just feel the pulse. And if you feel the pulse and the pulse goes away when you stretch it backwards, you have to hold it for a few seconds, 10 to 30 seconds, depending upon the comfort of the patient. This is a positive test, okay? So no, it's not a difficult, it's a very easy test actually. Yeah? Okay.
Yes.
Adson's test, anybody can tell me Adson's test?
So feel for the radial pulse and abduct the forearm.
Yeah.
And on abduct and ask the patient to look on another side.
Good. The patient has to look on the other side. Very good. So one is you feel for the pulse. Two is you pull the arm back and you have to compress the shoulder. Okay. You have to put a other arm on the shoulder and the patient looks to the other side. When you look to the other side, you're stretching the sternocleidomastoid and the scalene muscles. Okay. And that will cause the test to become positive. I'll show you.
The Adson test is designed to decrease the space in the interscalene triangle. The sensitivity is 79% and the specificity is about 76%. So because of the low accuracy value, it's difficult to tell how accurate this test is. You stand behind the patient, you have the patient put his arms on his lap, you ask the patient to rotate and extend his neck to the tested side. So he does an extension and then rotation, and then he takes in a deep breath and he holds the breath for 1 minute, for up to 30 seconds. The physician actually feels the radial pulse and looks for any change in the radial pulse volume. A modification of this test is when you move the arm 15 degrees and feel for the radial pulse with the patient breathing normal. In the first part of the test, the patient is also asked to take in a deep breath and hold his breath. This pushes the first rib against the vascular bundle. Thank you.
Okay, is that clear? What is supraclavicular Tinel's test?
So it is the percussion of the nerve root like a carpal tunnel syndrome at the supraclavicular area.
Well done, well done. That is correct.
Tinel's test is done for looking for supraclavicular tenderness pain. You get the patient to sit upright and feel for the supraclavicular fossa, and then take a hammer and tap gently on the supraclavicular area. If the patient gets tingling or he gets pain, then this test is considered to be positive. The specificity and the sensitivity of this test for thoracic outlet syndrome is only 46% specificity and 52% sensitivity. Hence, the interpretation of the test should be done with caution.
Good. What do you do for carpal tunnel? Tinel Sign?
Yes, sir. In the carpal tunnel, we percuss at the level of wrist, at the flexor carpal tunnel, and the nerve that is going toward the forearm.
Excellent. Excellent. Very well done. You're doing very well,
When
Raza.
we're assessing thoracic outlet syndromes, you've also got to assess the periphery of the hand to make.
So why do you all also need to assess this, Raza?
Sir, because in the differential of the outlet syndrome, there is also that the peripheral neuropathy can accompany with this.
Good. Well done.
Sure.
That is correct.
There is no evidence of carpal tunnel syndrome. I'll show you what is called as the Tinel test for carpal tunnel syndrome. What you have to do is lay the patient's hand out on a table flat with the wrist facing upwards. And you have to tap on the carpal tunnel. If the patient gets tingling or pain or increased sensitivity, then it is a positive test. And it means that the problem is arising from the carpal tunnel rather than the thoracic outlet. A further modification is the tapping should be done along the distribution of the median nerve. So you start with the index finger and keep tapping down into the wrist and then continue tapping along the flexor area of the arm into the elbow. At any point you get this positive, then it is, if you get symptoms, then it is positive. The sensitivity is around 60% and the specificity is around 52% of this test.
Okay, what are
When
the
we're
other
assessing thoracic?
What are the other tests for carpal tunnel?
The other is Allen and Phalen test.
Good. How do you do Allen's test?
Sir, Allen test is basically to check the patency of the radial artery and the ulnar artery.
Okay.
In this, first we ask the patient to clench a hand for 5 to 10 times to empty the hand, then push on the both side of the radial artery as well as ulnar artery. Then gradually release one side. For example, we first want to check radial, then we release the radial and check the perfusion of the hand with this.
Excellent. Well done. Very well done.
We're now going to demonstrate the modified Allen's test. In the modified Allen's test, you ask the patient to place the hand on a flat surface, and then the patient closes and opens the hand about 5 to 10 times. You then put a pressure on the radial and the ulnar artery, and again ask him to squeeze a few times. Yeah, leave it open. You now want to gently release the pressure on the radial artery to look for the revascularization of the hand from the radial side. You repeat the test by asking the patient to again squeeze the blood out of the hand a few times. You then place your hand on it and squeeze again a few times. Hold it straight. And this time you release the ulnar artery and show the refeeling. Usually you look for the reperfusion of the hand and it shows a patent radial or a patent ulnar artery.
Okay, well done. Phalen's test. Raza, you're doing really well. I'm so happy with your performance. Is Nikhil back or is not yet back?
Sir, I'm there, sir.
Okay, Nikhil, Phalen's test.
Sir, put a paper in between the fingers, and loosening of the paper is indicate there is a weakness of the muscles.
Phalen's test. Raza, you want to take?
Yes, sir. You have.
So I'll show you the
1 minute. Yeah.
Sir, in this patient is asked to extend and flex the arm and face the both hand downward and make them in a central position.
Yeah.
That you have shown us a picture.
Okay. So let me just show you the test again.
So I'll show you the second test for looking out for carpal tunnel syndrome. Because when you're assessing thoracic outlet syndromes, you got to make sure that the pathology is not somewhere else in the arm and the symptoms are not coming from a peripheral area. The carpal tunnel, as you know, lies in the flexor compartment, where it is a very tight compartment and 10 structures pass through the carpal tunnel to go into the hand. Any swelling or any inflammation will actually cause compression on the nerves and the vessels in this area. To do this test, you ask the patient to stand up straight. He's supposed to bend his elbows and flex his wrist and hold the position for 1 minute. This causes compression on the carpal tunnel and will cause compression on the median nerve. The patient, if it is positive, will get symptoms of tingling, pain, or anesthesia in the area of the thumb, the index finger, and the medial half of the middle finger.
Okay. So is this clear, guys? Hello?
Yes,
Yes,
sir.
sir.
So these are the tests. I mean, I'm telling you, this is a best case to get in the exam, because here you can actually demonstrate all these tests. So my suggestion to all of you is this video is out there on YouTube on Thoracic Gurus. Just before your exam, particularly the clinical exam, make sure you go through these videos, okay? So this will help you to show how we do the test. And you cannot talk about it till you practice on a patient. So best thing is catch hold of your brother or your son or anybody or your wife and make her sit down and do the test. And that way you'll be able to practice all these maneuvers. It is important to show that you understand what you're testing for. Okay, is it clear to everybody? Hello,
Yes, sir.
happy?
Yes, sir.
Happy, okay. Differential diagnosis of thoracic outlet.
Cervical rib, cervical band.
No, that we've spoken, what causes the thoracic. What are the differential diagnoses that you can think of? Everything is not related to the entrapment in these 3 triangles. So what are the other differential diagnoses?
Sir, CA lung. Cervical cancer.
Come with common things first. No? Yeah, common things, more common things first. I know, I agree with you, CA lung can cause it, but what are the common things that cause?
Lymph nodes.
Yeah. What is the commonest thing in the neck, Nikhil?
So cervical spondylosis.
Yeah, cervical disc problems and spondylosis. Yeah. Cervical vertebral facet disease. So I'll show you what it is. Good. Well done. So cervical disc, cervical vertebral facet disease, malignancies, peripheral nerve entrapment. Okay. What else? Other differential diagnoses? Other more different
shoulder joint problems.
Okay, what else?
There are some medical problems like multiple sclerosis, fibromyalgia,
Good.
hypothyroidism.
Yeah. What about brachial plexitis? You know,
Yes, sir.
inflammation of the brachial plexus. Shoulder pathology. Somebody said shoulder pathology. You said fibromyalgia. Well done. What else? Any vascular disease which can cause this?
Sir, Raynaud phenomena or vasculitis.
Excellent. Raynaud's vasculitis. What else can give rise to similar pain? Cardiothoracic surgery.
Sir, angina.
Angina. Excellent. Well done. So don't forget to rule out angina. Okay, it's quite important. What else? What are the other differences? There are a lot of differential diagnoses. Okay. Anyway, so let's get on with the investigation. So Nikhil, your patient has come to you. How are you going to investigate this patient?
Sir, chest X-ray, AP and lateral.
Good. Chest X-ray, AP and lateral. I really like that. And what else?
And sir, X-ray neck, AP and lateral.
Excellent. X-ray of the cervical spine. So don't forget this. Okay. Chest X-ray and X-ray of the neck is important. Neck, AP and lateral. Good. What else?
Sir,
You found a suspected cervical rib there. What are you going to do next?
Sir, CECT chest with arterial and venous phases.
Neck and chest, not
neck and
chest. Okay, neck and chest. You've got to look at the neck and chest. And what did you say? What else you want to do? Is it CECT or is it something else?
So arterial and venous phases.
Yeah, so actually you do angiography. So you do dynamic CT angiography. Okay. So there is some suspicion that there is some obstruction to the vessels. What is the best investigation for thoracic outlet?
Sir, obstruction to the vessel, the Doppler, arterial Doppler.
No, more important. What gives you the best delineation?
MRI. MR angiography.
What sort of MR? MR angiography. Good. Okay. What are the other tests? You've done all of this. You found that there is some obstruction. What are the other tests available to you? Anything else you want to do for this patient?
Nerve conduction test.
Excellent. Well done. Nerve conduction studies. Very important. Okay. It will give you an idea whether he's got some neurological problems or anything else going on. Okay. Any systemic neurological issues. Anything else? One more test I need.
Electromyography.
Excellent. Electromyography. Very, very, very important. Okay. All right. So if you're suspecting a venous problem, what is the best test for venous problems? In addition to all this,
Venography.
Sorry?
Venography.
No, before that.
Doppler.
Invasive?
Doppler. Venous Doppler.
Venous Doppler. Doppler is very, very sensitive. Okay. So duplex ultrasound is very good for this patient to look for venous engorgements. And then of course you can do CT or MR venography, or you can do contrast venography. The important thing about the venography is that you must tell both MR and CT venography is that you must do it at 90 and 180 degrees abduction. Okay, it's very important. You must do it in the positions that cause the symptoms. So during the investigation, you have to specifically in the request, you have to mention, please do MR in 90 degrees and 180 degrees abduction. Okay, very, very, very important. Any blood test you want to do particularly?
Coagulation profiles.
Excellent. Coagulation profile. Okay, very important. Yeah. So in the exam, remember all these things and go in the sequence that we spoke of and you'll do very well. Okay. So these are the reasons why you will get subclavian artery pathology. So you can have aneurysms, you can have post-stenotic dilatation, you can have fixed subclavian stenosis, you can have fixed stenosis with post-stenotic dilatation, you can have luminal filling defects and subclavian artery occlusion. This is the paper which has looked at a huge series of 41 cases with subclavian artery pathology. Okay? Subclavian artery, what is the best way to look for things?
So, arterial Doppler and then MR or CT angiography.
Very good. Angiography is the answer. Okay, so angiography, well done. So you have to look for angiography and see here, you can see it clearly. And again, angiography can be done in various positions, not just in one position, but you have to recreate the obstruction in the patient to show that there is constriction. Can you see the constriction here? You will be given this shot in the exam. Okay, sometimes we keep this in the exam and we give it to you and say, read this thing. Can you read this, Nikhil?
So this is a subclavian angiography showing the gradual tapering cutoff at the
what is the access for this study?
It's a Seldinger technique through the femoral artery.
Femoral artery. You try to do this through the femoral artery rather than through the radial, okay? Because yes, you actually don't want to go onto the side of the problem. So usually you try to do it through the femoral artery. And if you look carefully, you will be able to see a catheter coming up. Yeah? Catheter yes, coming up and going in there. Okay. So what can you see here?
So there is a filling of the dye, but after the three vessels, there is a gradual abrupt cutting.
This area?
Narrowing of the dye.
Narrowing of the dye. And what is happening here?
And then again, there is a free flow of the dye.
It's not free flow because this is free flow. Look at the color of the black. Black is free flow. This is not free flow. So there is obstruction and there is reduced filling distal to the obstruction. What area is likely to be affected here?
Axillary artery.
No, what area? Which triangle is likely to be affected?
So the costoclavicular.
Costoclavicular. This looks like it's in the costoclavicular. So when you discuss an angiography, you must say it looks likely in a costoclavicular area. Yeah, you must use this word so that the examiner knows that you're talking sense. Okay. Again, this is difficult to interpret because it's overexposed. So you can't see the ribs very well, but you can see the vessels much better. Okay. How is this picture produced, Nikhil? What is the test done to produce this picture?
So angiography.
Yeah, but what is this technique called as?
So digital subtraction.
Excellent. This is called as digital subtraction angiography. Okay. What do you do in digital subtraction angiography?
So first you take a picture of the without dye, the picture, and then you infuse the dye, and then again take a picture, and then on a monitor you subtract the image obtained before and the image obtained after from the before image.
Good. So you actually subtract, you digitally, it's not a technique that is physically done. It is a computer manipulation. Okay, so digital subtraction angiography is just an image manipulation, a bit like doing it on, the photographs that you manipulate. So first is normal anatomy without dye, then with dye, and both are placed one on top of the other, and the surrounding is all subtracted. Then you get only picture of the filled up artery, whichever artery that you do. Okay. All right. So this is showing you stenosis. So now let's come to the nice, easy part of this case. So what is the treatment for these patients? Can you give me 1 minute, guys? I'll just give me 1 second. Okay. 1 minute. Yeah, tell me, Nikhil, what is the treatment for a patient, your 36-year-old who came to you with left-sided tingling, numbness and things like that? What is the treatment for her? Nikhil, are you with me? Okay, Raza, take it. Nikhil,
Yes,
are you there or no? I can't hear you.
Yes, sir.
So what is the treatment for this patient who's come to your clinic?
So depending on whether the patient has this patient seems to have neurogenic and arterial obstruction, cervical obstruction, and symptoms due to cervical rib. So I like to educate the patient about the about the disease and the treatment. Mainly, I like to first counsel and ask the patient to do a lifestyle modification at the graduate physiotherapy.
So what lifestyle modification will you ask her to do?
Like in this patient, she's a wild type. She seems to be a steno or an office job. So I'll ask can she switch to the job of another kind?
No. You can't change a career of a person, man. What do you do?
So I'll teach her exercises. I'll ask her to do.
Yeah, no, but exercises later. Before that, what do you teach her?
Sir, posture correction.
Yeah, sorry?
To correct the posture.
Excellent. So first is posture correction.
Posture
Sita,
correction.
you can't tell her to stop her job here. So you just ask her to correct the posture, sit upright, make sure her chair is correct, make sure she's got support on the table, make sure the screen is well placed in front of her, make sure that her mouse pad is comfortable, and then there is a wrist support for the mouse pad. You can ask her to do a wrist support for the mouse pad. Okay. What else will you ask her to do?
Sir, then if she is having obesity or weight is increased, we ask
Excellent.
her.
So you ask her to do some weight loss, yeah?
Weight loss.
Yeah, so weight loss can cause this problem as well. Yeah? Okay, what else? Now come to the treatment. Nikhil, tell me treatment. What do you want to do?
Sir,
what are the treatments available to you?
Sir, physiotherapy.
Physiotherapy, agreed.
Okay, exercise. And I'll again review her after 1 month or 3 months.
Yeah.
If the symptom still continues, I'll review the physiotherapy. Is it done properly or not?
Okay.
And yes,
It's not. Symptoms are not going away, Nikhil.
even after proper physiotherapy.
Yeah, symptoms are not going away.
Then I'll ask the patient, I'll counsel the patient about need for surgery.
No. Before surgery, anything else you've got which you can offer her? Surgery is a big thing, no, Nikhil? You just
Yes, sir. Yes, sir.
anything else you can offer her, non-invasive or less invasive? Raza?
Yes, sir. Injection in muscle, that is known as Botox injection.
Good, Botox, yeah. So you can offer her Botox. Nowadays, safely you can say Botox for everything. Okay. So what is that called as?
It is with the help of needle, that is electromyographic needle Botox injection.
Yeah. So what is the technique called as? Chemodenervation. Okay. Chemodenervation. All right. So we spoke about physiotherapy. What else you can do? Anything else in addition to this? Relaxation exercises. Okay. Stretching exercises of the neck and shoulders, nerve gliding exercises, and strengthening exercises. So there are some specific exercises you have to teach her to strengthen the muscles of the neck, okay, and to strengthen the muscles of the shoulder girdle. So one is relaxation exercises, one is stretching exercises, nerve gliding, and strengthening exercise. Okay. So let's look at neurodenervation. In neurodenervation, what you do is you use an EMG guided needle. Okay, so the needle tip is connected to the EMG thing, and you look for active contraction. As the needle goes in, you look on the screen for active contraction. So active contraction tells you that you're in the correct area, and then you inject Botox or whatever else in specific muscles that you want to denervate, and then that will cause relaxation of the muscles, and that will cause release of the symptoms. Okay, all right. Now, when do you operate on this patient, Nikhil?
Sir, persistent symptom despite aggressive medical management.
Okay, so what's the duration you would give medical management for?
So around 6 months.
Yeah, 3 to 6 months. Agreed. Absolutely. What are the other indications for surgery?
Sir, post-aneurysm.
More importantly, in terms of symptoms.
Sir, worsening of symptoms.
Yeah, so limitation of routine activity, that is very important. So if the patient's routine activity is limited and sleeping, working and everything is limited, then you are unfortunately forced to offer them surgical relief. Okay, what else?
Yes, sir.
Inability to control pain with medication. Okay, these are the 3 indications for surgery in thoracic outlet. One is failure of improvement after conservative therapy. One is limitation of daily activities. Okay, that is very important. And the last is, of course, you have given medications and the patient still got pain. So, all right, now tell me, what are the various approaches or what surgery can you do?
Sir, open and minimally invasive VATS in open supraclavicular approach and a transaxillary approach.
Okay, so describe to me transaxillary approach.
After anesthesia fitness and single lumen tube, a patient in lateral position, hyperabduct the arm and then palpate the ribs, and in upper part of the axilla, horizontal incision, transaxillary incision, and then splitting the retracting the muscle. You are
I'm just going forward. Yeah. What structures will you encounter when you go across?
So the fat.
The fat, very good. And what else?
Yes, sir.
What else will you encounter? In the transaxillary approach, what else will you encounter?
Sir, intercostal brachial nerve that we should preserve.
That is correct. That is correct. Intercostal brachial nerve, which you have to preserve. What else? Actually, you don't really come across the
Anything.
subclavian artery and vein. You just,
Mhm.
as soon as you make an incision and you go through, you will end up on the first strip. Okay?
First. Yes.
What do you do to the first strip?
So I'll divide the sir, I'll divide the scalene anterior muscle,
And
then it will and then periosteum is elevated
yeah.
along the rib, and
What
at
do
the
you divide, beta?
costosternal junction,
Yeah,
costochondral.
you divide the rib itself, isn't it? You always divide. You make a cut on the rib. Can you see this cut on the rib? And
Yes,
cut on the scalenus muscle. Okay? So very good. So this is a sideways position and this is the axis. Yeah?
Yes, sir.
Okay. So I'll show you again. As you go in there, you usually do not encounter anything because when the arm is abducted, okay, abducted, all the structures are going away from you. Okay, they're coming out of the thoracic outlet and going away. So your incision is below all the structures. So as soon as you make your incision, you have only fat, and then the fat gets you directly onto the first rib. Okay, and then the moment you reach the first rib, you elevate the periosteum of the first rib, you cut the scalenus anterior, and you make a cut on the first rib. And sometimes you might even have to do further cuts on middle and subclavius muscle. Okay, depending upon what is the situation there, you can cut the middle and the subclavius muscle in addition to the scalenus anterior. And then you make a cut on the rib, and that gives you a complete release. You can make one cut or you can make two cuts. It completely depends on what is there on the table. Yeah, and so this is the release. Can you see that? Now the whole area is released and you've taken that piece of rib out and the patient is okay. You can do either of them. There are many ways to do this surgery. So you can either cut just the scalenus anterior and make a cut on the rib on one side, or you can make two cuts on the rib and remove a piece of the rib, or you can cut middle scalene, anterior scalene, and subclavius. When you remove a rib, you have to cut all three, but that is the most, the one that will give you the best results. When you take away the rib, the risk of recurrence is not there when you do this surgery. Okay, all right. Tell me about the supraclavicular rib resection. How do you do that?
Sir, horizontal incision 1 centimeter above the superior border of the clavicle.
Yeah.
Dividing the sternocleidomastoid.
Describe the surgery. No? What are you doing? Describe the surgery.
Platysma is divided the platysma, raising the upper flap.
Yeah. What
Then
comes below the platysma?
divide the sternocleidomastoid.
Yeah. Okay.
Lower end of the sternocleidomastoid.
Yeah.
Then you can.
Or you can retract it also. You can divide or you can retract it.
Retract.
Yeah.
Then omoid is divided.
No. You don't get omoid in that area. It's sternocleidomastoid and the platysma. And then what comes after that? What comes after that? The ribs. The fat pad. Okay, there's always a fat pad which is called as a anterior scalene fat pad. Okay. Then what do you do? So you have to dissect this fat pad out. Okay, it's always there, and so you have to dissect it and move it to one side. Yeah. Okay. Then what do? You've done this.
Then you can then divide the scalene anterior and the scalene medius.
Okay. Good. So
and then
divide the scalenus anterior. Okay. And then what else?
Scalene medial.
Okay, so here is the scanner's anterior divided. What do you have to be careful in this area?
So the brachial plexus, not to cause injury to brachial plexus.
On the left side?
Thoracic duct.
Good. And also the phrenic. Okay, phrenic runs in the lateral angle of your incision. So you got to be careful. You have to identify the phrenic. Always you have to, otherwise you'll cause paralysis of the diaphragm. Okay. So you actually divide that and clear out this area and cause the thing to open up. Okay. And then what do you do?
Then divide the rib with the rib.
You always divide the rib. Okay. So you retract the brachial plexus to the side and then you make a cut on the rib and then you divide the rib. Okay.
Yes.
What is the other access to this area? How else can you access it? Or if you're not able to get everything from the supraclavicular incision, what else can you do?
So the posterior approach.
You're doing the operation and you're finding it difficult to access the first rib.
Infraclavicular incision can be added.
Good. You can add an infraclavicular incision. Okay. So the infraclavicular incision will give you additional access to the first rib. Okay. Particularly the medial part of the first rib, you might not be able to cut from here. So if you're not able to cut from here, you make an infraclavicular incision and cut the first part, the medial part of the first rib. Okay. All right.
Yes.
So this is how you divide here. And one thing you forgot to tell me is the costoclavicular ligament. Okay. There is something called as a costoclavicular ligament, which you have to divide. See here the costoclavicular ligament that you have to divide as well. And what is the other muscle that you divide?
Subclavius.
Subclavius. Excellent. So you divide the subclavius and the costoclavicular and the scalenus anterior. Okay. And if you're going to take away part of the rib, then you have to divide the scalenus medius as well. Is this clear?
Yes, sir.
Yeah, see here. So one cut here, but the rib will not come out till you divide the scalenus medius. So that is why you have to divide. What is the other axis? Usually done in recurrent cases of thoracic outlet.
So it is usually the posterior Shaw-Paulson incision.
You might have to do a posterior Shaw-Paulson's or a posterior large axis, okay, and that will get you into this area. And what it will do is it will give you the remnants of the first rib. Sometimes the stump of if you haven't dissected it out adequately, then the stump of the first rib can cause compression of the nerves or the vessels, and the symptoms don't go away. So you might have to actually sometimes do a posterior axis and get that stump out of the first rib. Okay. What else can you do in terms of what are the other accesses that you have?
Sir, minimal invasive surgeries.
So what is the minimally invasive surgery you can do?
VATS and robotic.
Excellent. So what do you do in VATS or robotics?
So in VATS and robotic, the approach is through the chest cavity.
Yeah, good. What is the advantage and disadvantage of open versus doing a transthoracic rib?
So transthoracically, you can easily identify all the vessels that are moving from inside to the out, means outlet. You can see easily and identify all these vessels, and the rib is clearly seen through the inside.
Absolutely. The vision of the rib is much better through the inside because you don't see the vessels.
Yes.
You understand? When you're coming from inside, you just cut the rib on the inside. The vessels all lie outside your area. The only problem is going around the rib is the difficulty. Yeah. So you have to going around the rib. You have to be very careful that you don't damage anything in the thoracic outlet when you're coming from the inside. The disadvantage is that because you're going transthoracic, you've got to do double lumen anesthesia. You got to put in a chest drain and all those things. All right. So that is the problem with doing it transthoracic. The hospital stay could be extended by a day or two if the patient has any chest problems following your surgery. But transthoracic is an excellent approach, and you can actually cut the rib without having to really get in touch with the vessels. So that is the advantage. Okay. All right. How do you cut a rib transthoracically?
So, but there are two ways. Either you can use a endoscopic cutter, rib cutter, or a giggly saw.
Yeah, good. So endoscopic rib cutter or a giggly saw. All right. Okay. Tell me complications that can occur after surgery.
Bleeding.
Yeah.
Nerve injury.
Yeah.
Brachial plexus injury.
The one thing you guys forgot to tell me in all of this is that you must have a nerve stimulator on the table. Okay, whenever you're talking about surgical operation, you must have a nerve stimulator on the table so that you can correctly identify the phrenic nerve and more than the brachial plexus, the various branches of the brachial plexus. What is special about anesthesia when you do this sort of surgery?
The neuromuscular blocker is avoided.
Yeah, so you don't give muscle relaxants, okay? That's quite important in this surgery. You should not give muscle relaxants. Why?
Sir, because we want muscle activity. If you paralyze,
you want to test for muscle activity and the nerve activity. So if you've given a neuromuscular blockade, then you won't know. Even if you stimulate the brachial plexus, you'll get no twitching of the muscle. So you actually want the twitching of the muscle. Okay. Complications, common complications. Go on quickly. Come on.
So on left side
thoracic or transaxillary, and you've cut the first rib. What is the most common complication that can happen?
The pleura can open.
Yeah, pleura can be opened and you can get a pneumothorax. Good. So what do you do if you've got a pneumothorax?
Sir, we can place a chest tube.
Place in a chest. Very easy. Then you can get vascular injury. You can get nerve injury. What are the 3 nerves that is likely to be injured in this operation?
Sir, one is the phrenic.
Yeah.
And other is brachial plexus.
Good.
And other can be sympathetic chain that is running around.
Sympathetic chain is too far out actually. You may not get that far. Because
then the long thoracic nerve of bell.
Long thoracic nerve of bell is the one. Yeah. And sympathetic chain, if you get, then you got to be very careful. It's quite posterior. So you're right, you can get a sympathetic chain injury, but usually it's not that common. But you must watch out for sympathetic nerve. Okay. Left side, what can happen?
Sir, the damage to thoracic duct, lymphatic leak.
So you can get chylothorax or you can get continuous chyle leaking out from the left side. What will you do if there is a situation like this? Post-op day 2, in your wound there is a sudden swelling, and you aspirate and you get chyle. What are you going to do?
So one option is local exploration, and if you found that there is a leaking point is there, then you can ligate this.
The most important option is local exploration, okay, re-exploration.
Yes, sir.
Because you know it's a local problem. You have operated in that area. So you need to re-explore. If there is chyle there, you cannot go down the route of, fat-free diet and octreotide and all that. You have to re-explore because this is a surgical injury to the thoracic duct, okay? How do you identify the thoracic duct on table?
Sir, there are many methods. One is we can ask the patient to take heavy cream of 100 gram, and it will increase the leakage at that area. One is.
So how do you do that? How do you give it in theater? How do you give cream? Just the patient is nil by mouth. So how can you take?
By NG tube.
Yeah, so NG tube 30 minutes before after anesthesia, you have to then inject, you have to down the NG, you have to give 200 ml of fat. Okay. What else can you do? Just plain fat or anything else you can do to
the we can add methylene blue and other dye.
So you can add methylene blue as well, and that will help you identify wherever that leak is. What will you do to the leak if you see it?
Sir, we can ligate it with a non-absorbable suture.
Yeah, so ligate it, either you tie it off or you put a liga clip, okay?
Yes, sir.
Yeah, but you got to be careful that your liga clip does not impinge on any of the neurovascular structures around there.
Yes, sir.
Okay, good. Well done. Well done. You guys are doing very well in this case. I'm very happy. Success rate of surgery?
Sir, in neurological TOS, it is about 65 to 70% at 5 years.
Well done. Recurrence rate?
It is about 30%.
Excellent. Excellent. And is neurological better to treat or vascular better to treat?
Sir, neurological.
Vascular.
Vascular is better to treat. Okay. Neurological may have other elements, and then once nerves are damaged over a prolonged thing, the recovery may be much, much slower. Whereas vascular, the moment you take away the obstruction, the vessels re-expand and the symptoms go away much faster. So vascular is better, gives you better results than neurological. Okay. All right. How do you do recurrent surgery? If the patient has recurrence, what do you do?
So
If the
there is,
patient has had surgery, but he's come back with recurrence, what are your treatment options, Nikhil?
sir,
Okay, Raza.
sir, again we will educate and physiotherapy.
Excellent. So don't just reoperate, okay? Because reoperation is very, very difficult in thoracic outlet. So you have to have education and physiotherapy, very important. Because already you've released the thing, and whatever is causing is a minor problem which is compressing on the nerves. So just simply by doing physiotherapy, muscle building, neck exercises, you might be able to defer the surgery. What are the other options you have in recurrent cases? Second time recurrence?
So do we have to see the previous operation notes? Whether
Yeah, you have to see the previous operation notes. You have to know what's been done.
Because for the periosteum, whether it is left intact.
Yeah. Previous operation notes, previous radiology, and current radiology. So you do everything that you have done. So what else can you do? You have given him physiotherapy. What are the other options available to you in this patient?
Botox injection.
Excellent. So don't just operate on these people. Offer Botox. Okay.
Botox.
All right. Should you do both sides at the same time? If the patient had bilateral symptoms, should you do both sides at the same time?
No, sir.
So what is the standard protocol?
So at least 1 year in between.
Yeah, so you don't operate both sides at the same time. Otherwise, the patient will be bilaterally, crippled,
Handicap.
and you will be really in trouble, medical legal trouble. So it's important to know that you only offer the other side after 1 year. Let one side settle down completely before you offer surgery on the other side. Okay. All right. This is just a pathway for the venous. This is, you have to, before you do anything else, you have to make sure think about venous thrombolysis. Okay. Can you see that venous thrombolysis? That is quite an important thing. And post-operatively also, you have to give anticoagulation. Okay. How long do you give anticoagulation post-op?
Sir, 3 months.
Yeah, 3 to 6 months. Okay. Good. What do you do in a vascular thing? What sort of surgery do you want to do?
Sir, along with the rib resection.
So one is rib resection. Then what else?
If there is a aneurysm, then arterial reconstruction.
Good. So you might have to reconstruct the artery. That is correct.
And in case of venous, thrombectomy, embolectomy basically.
Embolectomy. So in a distal emboli, if there is evidence of thrombus or there is anything, you have to open the vessel and pass in a Fogarty's and do a distal embolectomy. Okay. All right. So subclavian artery reconstruction. Any other options you have for endovascular, for arterial reconstruction?
See, endovascular intervention.
What endovascular intervention can you do?
So the stent placement.
So you can put in endovascular reconstruction or endovascular stenting. Okay. You can do it for stenosis, and you can also do it for aneurysms. Okay. So there is a lot of papers which talk about endovascular stenting and aneurysms. Okay, very well done. I am actually exceedingly happy. I feel very good that you guys have done very well in this. Okay. Now, do we still have exam going people with us, or do you want me to discuss some more things with you guys, or you want me to just call it a day? I have actually prepared a small presentation on TEG because this guy's Biswarup asked me to talk about it. Is everybody happy with TEG or not happy with TEG? Soumya, are you happy with TEG?
So I think we can have the presentation, sir.
Yeah, it's a very small one, nothing difficult. But because Biswaroop specifically asked me to explain TEG, even for thoracic guys, just stay on, okay? Because TEG is something that you might face in your this thing. So Soumya, I'll discuss with you if that's okay, because you're the more cardiac person in this group. Is there anybody else who's cardiac specifically? Okay. So Soumya, let's have a discussion. Okay, this is not nothing. This. So Soumya, what is TEG? How do you do TEG?
TEG is a thromboelastogram. It is
Yeah.
used to check the strength of the clot that is formed.
Excellent.
So that helps to find out the difference from other coagulation tests that you do is the other tests don't check the role of platelets.
Okay.
But a TEG uses combines the role of platelets and coagulation factor and also the fibrinolysis which happens after that.
Excellent.
So
So how do you do the TEG test? What happens in the tube?
There are two ways. One is like there is a pin which stays stationary and the blood rotates around it. The other one, the blood stays stationary and the pin rotates. So it depends on what machine you're using.
That is correct. And so you actually create the movement to create a venous blood flow. You're simulating the venous blood flow. And you're simulating blood clot formation. And what are you looking for in the TEG? What does TEG read actually?
You find we see the time it takes for the clot to form and the thing to stop moving.
Yeah, you're absolutely right. But what is it reading? How does it read these? How does this chart come about? What is it reading? When the clot is forming, what is it reading?
I'm not sure, sir.
It's reading the resistance to the rotation. Okay. As the clot is forming, you're actually studying a kinetic process. It's called as a kinetic process. And the TEG is reading the resistance of the movement to the formation of the clot. Okay. Does that make sense?
Yes.
Okay. All right. So let's look at what does it provide information? What can you read from a TEG?
You can know the times it takes for the clot to form.
So clot formation, good. What
yeah,
else?
you can check the time it takes for the clot to attain maximum maximum clot formation,
yeah,
and time for fibrinolysis.
So it looks at clot formation, also looks at
Breakdown,
clot breakdown, and it can help you reflect on the coagulation cascade. Anything else that I missed out in this? One more point.
Not sure.
Platelets. It can give you a platelet function, okay? Because on the basis of the TEG, you can actually decide whether to give platelets or not to give platelets. So it looks at all of these, all right? Okay. So what is on the x-axis of a TEG? This is the x-axis, and this is the y-axis. So what's on the x-axis of the TEG? You can see it here. What is on the x-axis? Time. Okay, x-axis is time. So as you're moving along, this is the time it's taking for the clot to form. What's on the y-axis? Soumya, are you with me?
Y-axis is the. I lost internet connection in between.
Okay.
Y-axis measures the thickness of the. Yeah, I'm back.
Yeah. So what does the y-axis measure?
Hello.
Yeah, I can hear you.
Measures the thickness of the clot.
Yeah. So what is that called as? Thromboelasticity. Okay, it measures the thromboelasticity. So x-axis is time and y-axis is thromboelasticity. I'm sorry about the spelling mistake. It's thromboelasticity. Okay. So now, Soumya, identify these various parts of the TEG. So what is this? What is R?
R is the time it takes from the beginning of the process till the clot starts to form.
What does R stand for? What is it called as?
Reaction time.
Good. So R is reaction time. So it's the latency until the clot formation begins. And the amplitude, what is the amplitude of R? How much does it move up normally? About 2 mm. Okay. So the movement of the R is about 2 mm on the y-axis. Okay. What is normal R?
Not
Are you with
sure,
me?
sir.
Normal R?
Not sure.
3 to 9 minutes.
1 to
You
4
must know
seconds.
this. 3 to 9 minutes is normal R. Okay. You must know this. This is an MCQ question, by the way. Normal R time. Yeah. Okay. Let's look at the next factor. What is K value here? There is something called as K value. You can see this K.
Yeah.
What is K value? Anybody wants to take it? If there are any cardiac boys, any international guys with cardiac experience? Salman, are you cardiothoracic? What is K? End of R until the clot reaches 20 millimeters. Okay. So here R is starting at 2 millimeters till the time it reaches 20 millimeters. It is the, it's called as the, it is called as K, and K value specifically represents the clot formation. What is normal K?
That is 1 to 4
Yeah,
minutes.
so 0.5 to 3 minutes.
1 to 4 minutes.
Yeah, 0.5 to 3 minutes. Different textbooks give you slightly different numbers, but on an average, 1 to 4 is acceptable. 0.5 to 3 minutes is okay. What is alpha angle?
Alpha angle is this line the K makes with the x-axis.
Yeah, so it is the tangent to the curve at K. So this is K. So this tangent is called as alpha axis. What is normal alpha axis? Alpha angle?
55 to 75.
Yeah,
something
54,
45 to
that's
50.
good. That's good. These numbers are important. Again, this will come in an MCQ. That's why I've brought these numbers up for you. Okay. Okay. What is maximum amplitude? MA. Can you see this MA? What is MA?
That is the thickness of the clot that
So
forms.
what does it represent? The thickness of the clot forming. What does it tell you? It tells you the strength of the clot. Okay. How strong is the clot? So that's the total clot strength. What is normal MA?
55 to 75 mm.
Yeah, good. 51 to 78 mm is normal MA. Well done. What is LY30? Lysis time 30. See this LY30? What is LY30 on a text?
So after the MA, the clot starts to lyse.
Yeah.
So you take 30 seconds from MA and
30
you
seconds?
see how much the height.
30
30
seconds?
minutes.
30 minutes.
30 minutes.
Yeah, so it's a percentage lysis after 30 minutes. Okay. This is LY30. So you have to wait 30 minutes and then you will know how much is the percentage of the clot lysis. What does it represent?
It represents that lysis strength of ability of the fibrinolytic
So it's
system.
the fibrinolysis stage of clot development. Good. What is the normal for LY30 on a TEG?
I'm not sure.
Again, 0 to 9%. 0 to 9% is what is the thing.
Okay.
So this is how a normal TEG would look like. Okay. So there is R time, there is the K time, there is your maximum amplitude, and then there is LY30. Okay. Always a TEG is interpreted in 4 factors: R time, K time, maximum amplitude, and LY30, and of course the alpha angle. Okay, so those 5 things which I just told you, whenever you have to interpret a TEG graph, you have to interpret in all these factors. Okay, so here is a TEG which is showing delayed clot formation. Now I'll just explain to you what is happening in this. Okay, here the R time is prolonged. Can you see that? It's a prolonged R time. All right. Here the K is also prolonged. So this is stretched up quite a lot. Okay. The alpha angle is decreased. It's very, very stretched out. The alpha angle that it is forming is decreased. It's less than 50 degrees. And the MA time, the maximum amplitude, is decreased. Normally the TEG will be up like this, but this is the maximum amplitude is decreased. Hence, this suggests that there is a problem here So this is a delayed, this is clot formation. Any problem in this area is a problem with clot formation. Any problem in this area is a problem with fibrinolysis. That's how you interpret. So this is clot formation, first half, and the second half is fibrinolysis. So whenever you get a prolonged R, then that is always suggestive of a delayed clot formation, okay? If the patient is on platelet blockers, what you will get is normal R, but the K gets prolonged, okay? K is prolonged. The alpha angle will be normal, but the maximum amplitude will be decreased. You must know these are, again, these are from the MCQs. So they will tell you there is a there's a TEG which has got normal R, normal K. Alpha angle is also normal, but the MA is decreased. What is the potential diagnosis? So the patient is on platelet blockers. Okay, that's the way you interpret these things. Okay, in fibrinolysis, this is normal. Okay, but this is prolonged. Can you see that the problem is all in the second half of the cycle. So there is accelerated clot breakdown. R is normal, K is normal. The MA is decreased because there's some problem with the clotting cascade, but the LY30 is increased. This is the key thing, that LY30 is markedly increased, and that usually represents a fibrinolysis. In hypercoagulation state, the R is decreased severely. So there is a problem here. So R is decreased, the K is shortened because it's clotting very fast. Because it's clotting very fast, the R becomes shorter, the K becomes shorter, and there is the alpha angle becomes increased. Okay, so there is an increase in the alpha angle, and the maximum amplitude, because it's making a very big clot, or the patient is in a hypercoagulable state, the maximum amplitude of the clot will be increased. Again, this is an MCQ. Okay, so you will be showed either the graph or you will be given these points, and you will be asked to identify what is the clinical condition of this patient. Is it making sense? Hello?
Yes, sir.
Yes? Others, are
Yes,
you
sir.
understanding this or no?
Yes, sir.
Yeah, this is, it's not something that you do routinely, but it's worth knowing. There are two more situations that you have to study. So we studied, one is delayed clot formation. We looked at the presence of platelet blockers. We looked at hypercoagulable state. We looked at fibrinolysis. Now, two more things in a TEG that you have to study is, one is DIC. You have to understand what is the graph in an early DIC. So there is accelerated clot formation and breakdown. So DIC affects both parts of the TEG. Okay, so there will be decreased R, decreased K, alpha angle will increase as you saw in hypercoagulation. So clot is forming early and breaking down early. But the amplitude is also increased, but LY30 is increased. Can you see that? LY30 is grossly increased. So that is suggestion that this is early DIC. And when you finish the early DIC, then you go into late DIC, and in late DIC, everything gets prolonged. So there is a prolonged R time, a prolonged K time, alpha angle decreases, and the MA is decreased. So this is in late DIC where everything gets stretched out quite a lot. Did this make sense what I said? I went a bit fast because I want to put everything into context. So I'll quickly go through these again. So in a delayed clot formation, R time, K time is prolonged, alpha angle decreased, everything is decreased. When everything is decreased, it is always a delayed clot formation. Okay, when everything is a problem, then it is a delayed clot formation. When you have normal R time or K time, normal R time, but K time is prolonged and the amplitude is decreased, you're probably into platelet blockers. Something is blocking the formation of the clot. Okay, so that's what it is. When you are in a fibrinolysis, the first half remains normal, but it is the second half that is increased. So LY30 will be increased because the fibrinolysis is not doing well. If you are in a hypercoagulable state, then both are affected. The first half and the second half are affected. Okay. So R time decreases, K is shortened, alpha angle increases, and maximum amplitude gets affected. And early DIC, again, both get affected because hypercoagulable in early DIC, and then late DIC, everything gets shortened and it gets squeezed in. Does it make sense? Hello? Or was it confusing?
Makes sense.
Soumya, are you okay?
So
Okay, now what is the advantage of TEG?
it helps identify if you don't have individual factor assay, TEG helps to identify what component of that should be replaced.
Yeah, so the
It,
first thing advantage of TEG is you get results immediately. You don't have to wait for the lab to give you the results of clotting profile, right? So you have results available immediately. How soon can you get K and R time?
Not sure.
5 minutes.
Okay.
Yeah, you get, because that's what you're looking, isn't it? In the first 3 minutes, you want to see whether the K and R time is there. So within 5 minutes, you'll get a K and R time. When will you get, if once you're interpreting the, when will you get MA and alpha angle?
MA will be in 20 minutes, 15 to 20
15 to
minutes.
20 minutes. 15 minutes actually.
Yeah.
So 15 to 20 minutes. When will you get LY30?
30 minutes.
No, actually, because it's 15 minutes plus 30 minutes.
Okay.
Because the clot lysis, it is after the clot formation. It is 30 minutes to the clot lysis. So it's 45 minutes. Yeah.
Okay.
LY30 will come back in 45 minutes. So, okay, if I tell you that the R time is prolonged, what are you going to give to the patient?
FFP.
Good. When R time is prolonged, you give FFP. If I tell you that there is narrowing and the alpha angle is decreased, what are you going to give to the patient?
Platelets.
Yeah. Platelets, and more importantly, better than platelets,
Cryoprecipitate.
cryoprecipitate. Yeah. So platelets and cryoprecipitate is what you do. If the maximum amplitude is decreased, what are you going to do? This is MCQ, by the way.
Again, platelets.
Yeah. And what else do you have? Any other option? One is platelets, and then the other one is?
The drug arginine vasopressin.
Yeah, desmopressin. Okay.
Yeah, desmopressin.
So you can give platelets or you can give desmopressin, which is DDAVP. If the patient has got fibrinolysis,
You give tranexamic acid or
and what else?
protein, EACA.
Yeah, so aminocaproic acid or tranexamic acid. Yeah?
Yeah.
Okay, so that's easy. That's what TEG is all about. And TEG can come as a question. In fact, in the exam, we might keep one of these. In a Viva, we usually keep one of these. Okay, we just keep the chart and we ask you, can you interpret this? So whenever you interpret, you have to talk in terms of, this is the interpretation. You talk in terms of R time, K time, alpha angle, maximum amplitude, and LY30. Okay? And you must know that this x-axis is time and y-axis is thromboelasticity of the clot. And the first half of this reading is clot formation, and the second half is actually telling you about thrombolysis or fibrinolysis that is happening. Is that clear?
Yes, sir.
Okay, thank you very much, guys. Okay, so that's fine. I think we don't have enough people today, so let's call it a day. Do you want to do some MCQ revisions, or do you want to just call it a day? What's the time now? It's 11:15. We've almost gone 2 hours. So 10 minutes I can give you for some MCQs. You want to do that?
Yes, sir.
Actually, I want to do some graphs with you before that, because that is important in the exam. Sorry, just one second. I'll do some graphs with you. Let me just bring out the graphs. You got pen and paper?
Yes.
Okay. Identify. Let me just go. So this one we did the other day. This one we did the other day, but somebody quickly tell me what is 1, 2, 3, 4, 5, 6.
1 is absolute refractory period.
Yeah.
2 is when the potassium channels open, fast potassium channels open.
Yeah.
3 is when, fast sodium channel, sorry, but 2 is when the fast sodium channels open. 3 is when the potassium channels open and potassium starts leaving the cell. 4 is when calcium channels close and there it reaches a plateau. Phase 3 or 5 is when calcium channels open and potassium also keeps leaving.
Okay. So yeah, that's
6 is leaky potassium channels.
Oh, okay, leaky potassium channels. Tell me the phases of cardiac cycle.
So 2 is depolarization, 4 is plateau, and 5 is repolarization.
So let's start with 0. What is phase 0?
Depolarization.
Initial rapid depolarization. Okay. Phase 1.
Phase 1 is a refractory period, absolute refractory.
No, it's rapid depolarization. Phase 2.
Okay. Phase 2 is plateau.
Slow repolarization. Phase 3.
Rapid repolarization.
Phase 4. Resting membrane potential. Okay. All right. Okay. Tell me Starling's law.
Frank-Starling's law is the force of contraction of the muscle is dependent on the initial stretch the muscle has.
Excellent.
So,
good. So how does that correlate into clinical practice?
So during up to a phase of dysfunction, cardiac dysfunction, if you increase the preload, the heart is able to compensate and maintain stroke volume and cardiac output by maintaining Frank-Starling's law.
Good. So it is the stroke volume that you're looking at. Good, fantastic. So more blood in the heart, the higher the end diastolic volume, the more the sarcomeres are stretched. And then what happens after a certain point?
After a certain point, this the muscle becomes refractory to this law, and then because it's too stretched and doesn't help, so the cardiac output and the stroke volume drops.
Excellent, well done. Can you draw the Frank-Starling law on a graph? I want everybody to draw, okay, if you can. Can you show me a graphical representation of Starling's law? Sometimes we do this in the Viva. We give you a paper and say, draw the Frank-Starling's law. Let me know when you're happy, and then I'll show you the graph. Is everybody doing it? Or at least some of you doing it?
Trying to.
Okay, that's fine. All the graphs that I'm showing you are important for the exam. These are the ones that come. An MCQ can come also on this. Yes or no? Quickly. Somebody has to say yes, so I'll show you the graph.
Yes, yes.
Yes?
Yeah.
Okay, sorry, this is the graphical representation. Okay? So it stretches up to a normal thing and then it starts to fall. But if there's a sympathetic stimulation, it goes high up, the stroke volume can increase. But in a failing heart, the stroke volume will fall flat. So actually, this is the line that you have to draw. But on the y-axis will be the stroke volume. On the x-axis will be the end diastolic. So when we are looking at you drawing the graph, what we are looking is what's on the x-axis and what's on the y-axis. So end diastolic volume on the x-axis, stroke volume on the y-axis. You can stretch it. The stroke volume keeps going up. After a certain point, the heart will just give up and that will just start to fall down. Okay, so any more increase after this point, any more increase in the end diastolic volume will not affect the stroke volume. In fact, it starts to fall down. Okay, does this make sense, guys?
Yes, sir.
Yeah. Okay, so this, you must know this graph. It's a very easy graph to draw. But the important thing is what's on the x-axis and what's on the y-axis. Okay, somebody come in and tell me. Any of the international guys can come in and tell me. Yeah, somebody else participate. Salman, what are these numbers? This is intracardiac pressures. Tell me 1, 2, 3, 4, 5, 6.
Well,
One.
good afternoon. Can you hear me?
Yeah, I can hear you very well, Salman. Go on.
All right, so this is RA pressure 3.
No, what is 1? Start with 1. Tell me what is the number there. I want you to tell me the number.
One is aorta.
Yeah, what is the
So
number?
aorta systolic, it goes to 120.
So 120
And
by 80.
diastolic,
Okay. 120 by 80, I agree with you. What is 2?
and 2 is pulmonary artery pressure, which is between 15 to 25.
Okay.
milli-
So 25 to
mercury.
15 you should say, rather than 15 to 25. Yeah. What is systolic and what is diastolic? You have to tell me the systolic and the diastolic number. You always say the systolic first and then the diastolic next. So what is 2?
Yeah, 25 to 15.
Excellent. Well done. What is 3?
Then 3 is the RA pressure,
Yeah.
which is again 0 to 5 and 10.
Okay, 0 to 5. Is there any diastolic?
Yeah, there is 5 RV in the diastolic. That is 10 to 15.
It's just 0 to 4 or 5.
Almost same.
You don't do diastole. What is 4?
4 is
In
LA
ATM,
pressure.
you don't talk about diastole. 4?
Pressure.
Sorry? Give me a number.
15 to 20.
5 to 10, I think. Okay. What is 5?
5.
We're losing you, Salman. We can't hear you. What is 5?
I have a connection problem here. Sometimes I listen, sometimes it goes on.
Don't worry. Just try 5.
It's diastole, sir.
Sorry. Give me a number, Salman.
I gave you number 3 times, sir.
Sorry, I didn't hear you. I apologize. I didn't hear you. Number 5. What is it?
5, 10.
There is a systole and a diastole because it's a ventricle.
Yes, sir.
So what is the number?
The 10 is diastole, systole, and 5 is diastole.
10 and 5. No, that's a lower figure. What is normal? You just said 25 here. Now PA pressure 25. So the same pressure will be systole here.
Yes, sir.
So 25 over 0 to 4. Yeah. What about?
You're talking about RV or LA?
RV. This is RV. Number 5 is RV. Number 6 is LV. LV, what is the number?
Well, LVS is 80 to 120. I was in LA.
Okay, so this is the answer. Okay, so don't forget this. You must tell systolic and 120 over 80, 25 over 15, 25 over 0 to 4, 120 over 0, and this is only 5 to 10 and 0 to 4. There is no diastole there. Okay, there's no diastolic pressure. Somebody tell me what are the phases of a cardiac cycle? Anybody else wants to take it quickly? Come on, this is your time. We've got 10-15 minutes. We can quickly go through a few things. Soumya, you want to take it? This is very easy question, nothing difficult. Phases of a cardiac cycle?
Systole, diastole. In diastole, you have.
So tell me what happens in contraction in terms of valves. Before we talk about phases, just tell me what happens in systole.
Okay.
In contraction, what happens? In systole, contraction, what happens? Which valves are involved?
The aortic valve is open and the mitral valve is closed.
Okay. What about the tricuspid in contraction?
Yeah, the AV valves are closed and the semilunar valves are open.
Okay, so mitral and tricuspids are closed. Ejection.
Which phase you are talking?
This is the ejection phase.
Yeah. No. Yeah. So what happens in early ejection? What is happening?
Okay, so we'll start with atrial contraction, sir. So atrial contraction happens in late diastole.
Wait, one minute. I'll go back to the phases. Okay. Yeah, I think you're getting confused because I didn't talk about phases first. So let me come back to the phases. Okay. So come to the phases. Phase 1 is what?
Phase 1 is atrial
contraction.
Yeah.
What is phase 2?
Phase 2 is isovolumetric contraction.
Well done. Phase 3?
Phase 3 is rapid ejection.
Good. Phase 4?
Phase 4 is reduced ejection.
Excellent.
Phase 5 is isovolumetric relaxation.
Good.
Then rapid filling, reduced filling, and then again goes to atrial contraction.
Excellent. So now we'll come back to this cardiac cycle and we'll talk about this. So systole, what is happening?
Okay, so systole actually starts with isovolumetric contraction where all valves are closed, and then the aortic and the pulmonary valves open. So there is a phase of ejection, rapid ejection. Then as the pressures equalize, it becomes reduced ejection. And at one point, the aortic pressure is higher than the ventricular pressure. So it goes, the valves close.
Yeah.
This starts isovolumetric relaxation. Then at when the pressures reach a point where the ventricular pressures are lesser than the left atrial or the atrial pressures, the AV valves open. This leads to rapid filling. Then it goes to reduced filling. Then you have the phase of atrial contraction.
Okay, so this is the whole graph. Okay, you must know this graph. Okay, this is quite important. This graph is quite important. I mean, I know most cardiac surgeons know it, but it is important for you to be able to explain it to us in the exam. Yeah, so 1 to 7 phases. You must know which phase represents what and what is happening to the valve and what is happening to the ventricle and what is happening. So this red line you must be able to reproduce for us in the exam. Okay. So now explain to me, here is atrial contraction. What's happening here? How does atrial contraction initiate? Anybody? Soumya, take it. How does atrial contraction initiate?
Of stimulus from the SA node and travels.
SA node depolarizes. What happens to the blood flow?
Blood flows from the atrium to the ventricles.
How much percentage of the ventricle? Atrial contraction contributes how much percentage to the ventricle? 30%. 30%, you said? Okay. Did you say 30%? Your voice is breaking.
I said 30.
It's actually 15% of the ventricular filling. Okay?
Okay.
All right. Isovolumetric contraction, what's happening?
So both valves are closed. The AV valves and the semilunar valves are closed.
Yeah.
And the pressure inside the ventricle increases when the volume remains the same.
Good. So that's why it is called as isovolume contraction. Isovolumetric. Same volume, but contraction. So the pressure goes up rapidly. Third phase, rapid ejection. What happens again?
During the rapid ejection, the semilunar valves are open. The aortic and pulmonary.
Why do the valves open?
Because the pressure generated inside the ventricle during isovolumetric contraction exceeds the aortic pressure or the pulmonary pressure.
Well done, well done. And that causes the valve open. Okay. Yeah. And then what happens to the blood?
So, this is there is an active ventricular contraction and blood is ejected from the left ventricle into the aorta or the right ventricle into the pulmonary artery. And then it comes to a phase where the volume of blood inside the left ventricle is less, and also simultaneously aortic pressures are rising. So the flow is less, so it goes to reduce ejection.
Why is the phase of reduced ejection there?
Because the pressures are starting to equalize.
Equalize. The pressures are equalizing. That's the answer to the question. Okay. All right.
Hmm.
Isovolumetric relaxation.
So when the aortic or the pulmonary pressure exceeds the ventricular pressures, the valves close.
Yeah.
The AV valves are already closed at this point. So when the ventricle muscle goes into a phase of relaxation, then the volume remains same.
Okay. So same volume, but relaxation. So the pressure drops in the left ventricle. Okay. Rapid filling.
Rapid filling is when the ventricular pressure falls below the atrial pressure, the mitral and the tricuspid.
Yeah.
And this leads to a fast filling from atrium to ventricle.
So it's a rapid filling of the ventricle. Okay. And then low atrial pressure due to suction effects results in the rapid filling. Okay.
Yes.
Because the atrial pressure is less, so there is a suction into the area, and that causes the rapid filling. Reduced filling.
Reduced filling is when the ventricular pressure starts to increase, the atrial pressure, the passive flow comes down from the atrium to the ventricle.
Excellent. I'm sorry to ask you very basic questions. You know this inside out, but the
No,
problem is when you're put on the spot, you become a little,
I've been like having real memory lapses when I was in
No.
exams.
You know this inside out for me. I know you know this inside out, but it's just that I'm putting pressure on you, and that's why you're not able to. But you're doing very well, actually. I thought you did very well. First heart sound.
Opening of the aortic valve.
Anybody else?
Sorry, closing of the aortic valve. Sorry.
Closure of the aortic.
Closing of the aortic valve.
All right. Best heard where?
Aortic area corresponds to second left intercostal space.
It's actually the apex that you best hear. Okay.
Okay.
Loud first heart sound in.
Mitral stenosis.
Mitral stenosis.
And what else? Hyperdynamic circulation. Okay. Second heart sound.
Closure of arterial aortic valves. Aortic.
Second heart sound is a closure of the mitral valve or the AV valves.
Yeah, so AV valve. Good. You're right, Nikhil. So good. What is physiological splitting?
Variation with respiration and inspiration.
So A to P2. Why does this happen?
Physiologically, the blood flow in the right atrium and the right side is more following an inspiration. The negative intrathoracic pressure increases the blood flow on the right side. So there is more volume of blood which goes across the pulmonary valve. So that causes a delay between the aortic and the pulmonary valves.
Excellent.
Closure.
Excellent. Because of increased venous return. Okay. All right. Third heart sound.
Failure sound.
When do you hear a third heart sound? Which phase of the cardiac cycle is it responsible for? Yeah, which phase? There's 1 to 7 phases, no? So which phase?
In the rapid filling.
Rapid ventricular filling. You're right. Adults or children? Where do you hear it good? Better.
Children's.
Children. Best heard in children. Okay. Fourth heart sound.
Fourth heart sound is heard just along with the atrial contraction, and that.
So it's the atrial. It's an atrial sound that you hear. But in what situation will you hear the atrial sound? You normally don't hear the atrial sound. But if you hear the fourth heart sound, what does it signify? What's happening to the ventricle?
Enlarged.
Sorry?
Enlarged, dilated ventricle.
Stiff.
Hypertrophy, sorry.
Yeah. Stiff.
Hypertrophy.
Yeah. Ventricular
Yeah,
hypertrophy or heart failure. Yeah.
Yeah.
Okay, good. One or two quick questions now. Okay, let me just show you this. Take a pen and paper, draw the JVP.
Yes, sir.
Okay, good. Okay. Everybody happy? Shall I show it?
Yes, sir.
Okay, that's your JVP, all right? So now you have to tell me there is A wave, C wave, V wave, X and Y trough and H wave. Okay, so what is A wave? Why do you get A wave?
The atrial plexus.
Atrial systole, good. When is the A wave absent?
Atrial fibrillation.
Good. Absent in atrial fibrillation. Well done. When do you get Canon A waves?
Aortic stenosis, I think. Aortic regurgitation.
Complete heart block, okay? The commonest cause is complete heart block. And then, of course, in stenosis, you get giant waves, okay? Giant waves in pulmonary tricuspid stenosis and pulmonary hypertension. Okay, C wave, what does it represent? Bolo, anybody can say. C wave, what does it represent?
Closure of walls.
Soumya, C wave represents what? Have we lost?
Closure of the valves.
The more than closure, what does it represent?
Bulging of the valves.
Bulging of the
onto
valve. Absolutely right. It's the bulging of the tricuspid valves into the right atrium. Okay, that's what it represents. So when there is isovolumetric contraction, all the valves are closed and the ventricle is contracting. So when the ventricle contracts, what it will cause is the valve to push into the right atrium. And so the C wave, which is the bulge you see here, is represented as the bulging of the tricuspid valve into the right atrium. Usually synchronous with pulse wave in carotid artery, okay? So when you see this in the carotid artery, you can actually correlate it. V waves. What is this V wave? Anybody can come in. I've got 9 people, anybody can come in. V wave. This is all activity happening in the right atrium. So what is V wave? Come on, guys. Basic physiology, man. Soumya, are you still with me?
The rapid feeling.
So it is the rise in the right atrial pressure before the tricuspid valve opens. No, it's the pressure rise before the tricuspid valve. When the tricuspid valve opens, it goes down. Okay? So V wave is the rise in the right atrial pressure before the tricuspid valve opens. What is the X descent? Why does this happen? This happens because the tricuspid valve bulges into the right atrium. Why does this happen?
It empties, the RV empties in this phase.
RV empties. So what happens to the tricuspid valve?
Down in the venous system.
The tricuspid valve moves down into the RV. That is why the pressure in the right atrium drops.
Yes,
yeah. So it is the tricuspid valve moving down during ventricular systole. You agree or no? The atrium is contracting, the tricuspid valve is moving down, and there is a negative pressure created in the atrium because the tricuspid is bulged down. What is the Y descent? Why is the pressure in the right atrium falling down suddenly?
Opening of the walls.
Which valve?
Atrioventricular. Mitral
valve, yeah. Tricuspid. Because we are talking about right atrial occurrence here, not about the mitral. So you have to say tricuspid valve opens.
Right.
And what is happening to the blood in this area, in this phase?
See, it rushes.
Yeah, so blood goes.
RA
Right.
into the
Okay. Somebody identify, not identify. Tell me the various lumens in a Swan-Ganz. What is a Swan-Ganz catheter? Somebody tell me. Cardiac boys, come on. Last question of the day.
oh, so it is to measure the cardiac output, systemic venous return, and the pulmonary wedge pressure.
Okay, good. So how do you float a Swan-Ganz?
What it we insert it through going through the chambers of the heart to the pulmonary vessel through the valves, and every chamber has different pressures and different tracing. So we recognize with the tracings that where we are, and when we went into the pulmonary capillary, then there are 3 ports, I think I remember. So for the pulmonary capillary wedge, for
4
the
ports.
RA and RV, 4
So
ports.
now take
One
your
is for
pen and paper. Take your pen and paper and draw a graph of floating a PA catheter. So what happens when the PA catheter is in the RA? What happens when the PA catheter is in the RV? What happens when the PA catheter is in the pulmonary artery? And what happens when you wedge it? 4 events I want to see. So PA catheter in the RA, PA catheter in the RV, PA catheter in the pulmonary artery, and wedge of the balloon. 4 graph in line, draw it in line, in sequence. So as you are floating, the PA catheter has come into RA. What is the diagram you'll have there? Then when it comes into the RV, what is the diagram you'll have? When it comes into the pulmonary artery, what is the diagram? And what is the diagram when you wedge it? I want to see the 4 in one line. Is everybody drawing or no? So what diagram will be there when the PA is in the RA?
When it's in the RA, it will be similar to the jugular venous
Yeah, so it will be JVP. Absolutely right. It will be like the JVP because JVP represents the RA pressure. What happens in the RV?
It will be similar to the cardiac output tracing we have made, but with lesser peak pressures.
Yeah, so there will be contraction and higher peak of the tracing. What will happen in the PA?
The peak will remain the systole, the peak will remain the same. The diastole will come less.
Good, very good.
It will
So
not
what
touch
is the
0.
pressure you will see? 25 over?
10.
Yeah, okay, 5 to 10 is all right. So I'll show you the trace now. And 1 minute. And what will happen when you wedge it? What are you reading when you wedge this balloon?
The balloon wedges in the pulmonary vein, and we see the pressure distal to the balloon.
Pulmonary artery, not pulmonary vein.
Sorry. Pulmonary artery, and we see the pressure distal to the balloon, which reflects the pulmonary, the rest of the pulmonary vasculature, the vein and the.
What are you trying to understand when you're trying to wedge it? What pressure are you trying to understand?
The pulmonary vein and indirectly the left atrial pressures.
Yeah, you're
the left side
indirectly
of the
trying to
pelvis.
represent the left atrium. You're trying to understand what's happening in the left atrium. Okay, so this is the graph. Okay, so this is your normal JVP. Just draw a normal JVP. The moment you come into the RV, you have the upswing, large upswing, just like the cardiac cycle. Then when you get into the pulmonary artery, the systolic remains the same, but the diastolic comes up. So 25 to 10, okay? And then when you wedge it, you're actually reading the left atrial pressure. You're actually reading the pulmonary artery and the left atrial. It's an indirect reading. You must be able to draw this trace. Okay, this bottom trace which I showed you, you must be able to draw this trace. And you must know what is on the x-axis and what's on the y-axis, okay? So this is time, or this is position of the catheter, and this is pressure. And this graph always starts 0 to 30, so that you can show the swing of 4 to 5 millimeters of mercury. Then you show 25 to 0, 25 to 0. Then the diastole goes up, so this is 25 to 0, 10, and then back to your PA pressure, to your left atrial pressure. Okay. All right. Thank you very much, guys.
Thanks a lot, sir.
Yeah, I'm sorry.
Thank you very
Thank you,
much.
sir. Thank you, sir.
Simple things, but they are important to revise in your exam. Okay. All right. Any questions you want to ask? Anybody has any questions to ask? I'll stop the recording. That's the first thing.